We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 231, Squint in Pediatric Ophthalmology, Session 18. And before I go further, I must say that we have reached over 1 million unique views and with 15,000 subscribers with 230 plus hours of curated teaching for all of you. And we are glad to bring this platform to you online at all times. And today we have with us Dr. Meenakshi Swaminathan ma'am, and she will be talking on exodeviations, terminologies, classification, etiology, symptoms, sign, diagnosis, and treatment in part 1. I request Pradeep Sharma sir to please introduce ma'am.
Thank you, Rolika. I think it's really a pleasure to introduce Dr. Meenakshi. She is one of the most interactive speakers, something which we all enjoy listening to, because of her getting involved in the talk so much, which gets each and every PG inspired. She has done a residency from PGIMER Chandigarh and University of Louisville, Kentucky, fellowship in Pediatric Ophthalmology, University of Iowa. But then it was loss of America and gain of India that she returned to India. And she's been working as a senior consultant and academic director at Shankar Nethralaya, Chennai, India. Currently, she's at Capstone Clinic, Chennai, part of teachers ophthalmology programs in India and other countries in collaboration with ICO. She's also a part of the Children's Healthy Eyes Bring Educational Reward Cheer project, a joint initiative between ICO and Orbis. The China chapter on August 2014 was by her. And numerous awards and accolades. Strabismus keynote by WSPOS 2021, visiting professorship at LVPI Bhubaneswar, Dr. S.S. Badrinath Medal of Honor 2013, Captain Subramaniam Best Video Film Award TNO8 2006, and many more to her credit. I think we are all going to be listening to her and her presentation, which will be really one of the best possible. Dr. Meenakshi.
Ma'am, you were on mute, ma'am. Yes, ma'am.
Thank you, Dr. Pradeep. And thank you so much for your very kind introduction. You are, of course, an inspiration for all of us, strabismologists in India. And Santosh, what a great platform. And something for posterity, for future, for generations. This is a wonderful initiative. Thank you so much for making me part of this. So, exotropia, and I've just named it part 1 for simplicity. No financial disclosure, and I have patient's permission to share photographs and videos. So, what are the learning objectives of this part 1? First, we are going to clarify some terminology, and then we will define various aspects of exotropia. Then we look at the classification, and we're going to talk a little bit about the clinical symptoms. And then, of course, the most interesting part is how to examine a patient of exotropia. And I really hope by the end of this talk, none of you will be scared, none of you will run away when you see a child entering the room or when you see a squint patient entering the room. So that is really the bigger aim of the talk. Exotropia. Yes, this is exotropia, where the eyes have deviated outwards, away from the nose. So that is exactly what the definition is. Eye deviating outwards. Now, it can be constant, one eye deviating the whole time. Sometimes the eyes can alternate. Sometimes the right eye might deviate, the left takes a fixation. Then the left deviates, the right takes a fixation. And that is called alternating exotropia with no preference. Sometimes there will be a preference of one eye. Even though they alternate, the patient may prefer to fixate with one eye, and you'll always find the other eye doing the deviation. Not only this, exotropias can also have vertical deviations associated with them. Exotropias can also have patterns, V pattern, A pattern, all of these associated with them. And we're going to see a lot more in detail in the next part because we have to learn how to manage patterns when they coexist with exotropia. Okay. Now, as far as exotropia is concerned, there is a little bit more terminology that you need to be aware of. So the first thing is exophoria. Then you have intermittent exotropia and then constant exotropia. So what are these? Exophoria, in which the outward deviation of the eyes is never seen in the manifest state, which means you really look at the patient and you don't see it. You see it only during the alternate cover test. And that too, the patient will quickly refixate even before a blink. The next stage is the intermittent exotropia, where the eye is deviated outwards, but it can be controlled by fusion or accommodation, that is focusing. And then the next stage would be constant exotropia, where the eye is deviating outwards constantly, and it is called a manifest deviation because it is seen even without breaking any fusion or breaking or changing the accommodation. So that is called constant exotropia. So we have exophoria, intermittent exotropia, constant exotropia. So you will see these notations in various charts. You will see it in textbooks, and you may want to use them yourself. And so this is explaining what these symbols mean. So an X prime is indicative of an exophoria. X with the T in brackets means an intermittent exotropia. And sometimes you will see notations like 30 VI, which stands for base in. So for example, 40 VI means 40 base in. Where I trained, we just called it 40 exotropia because that's what it is. So what do you mean by this basin? It's how you will place the prism in front of the patient to neutralize the deviation. In exotropia, we're going to place the prism with base in such that the apex is towards the deviation. So that is why it is base in. In some of the older textbooks, you will even see terminologies like RDS, which means right divergent squint, divergent, which means again going out. You might see RDS, ADS, which means alternating divergent squint. Okay, so it's good to know how to actually write. Now remember, there are other differentials and causes of exotropia. And again, we are going to see these in much more detail with some case examples in part 2. But just to give you an idea, there is sensory exotropia, which means the eye is deviated because of vision loss in the eye, which could be a corneal opacity. It could be a cataract. It could even be vision loss due to, say, optic atrophy, or something, maybe a retinal detachment, or maybe, any cause of vision loss in the eye can cause the eye to deviate. And that is called a sensory exotropia. Oculomotor nerve palsy, you're all very familiar with, where, the eye is down and out. So that is an important differential of patients with exotropia. And then you have Duane's retraction syndrome, typically type 2, but also sometimes in type 3. Now we call it exotropic Duane's. That is again an important differential. Then you have consecutive exotropia. And what do you mean by that? That is, surgery for esotropia happened and the patient got overcorrected, maybe right away or eventually or whatever. And that is called a consecutive exotropia. So when you look at a case of exotropia, you need to keep the differentials in mind. So then we go to the question of why does this exotropia happen? We all like to know why, right? So very simply speaking, there are lots and lots and lots of theories. If you open von Norden, which is an excellent book to read, if you want to know in depth. But I would suggest actually Dr. Pradeep Sharma's book, which is very practical and easy to understand concepts and applications of squint in your everyday practice. But if you look at these textbooks, they will talk of many factors of what causes exotropia. So number one are mechanical factors. That is something to do with the orbital anatomy. Maybe because of that, the way the muscles approach the globe, the way the pulleys, pulleys of the muscles are located, these may contribute to exotropia. And here you see a child with Cruzen syndrome, and you can see a clear exotropia of the right eye. Innervational factors are also important, and it may be because of variability in convergence. Innervation, remember, convergence is not happening, or if there is variability, then the eye is going to try and diverge and become exotropic. May also be disturbed equilibrium between convergence and divergence. In childhood, convergence is robust and can mask deviation at near. So if you ask the parents, was this present at birth? Was this present at early childhood? They may not have noticed the exodeviation at all because the convergence in a child is so strong. So it sort of overcomes or masks the exodeviation at near. Now, refractive errors also can present as a squint. Okay, and how does that happen? So let's, for example, take myopia, uncorrected myopia, which means in uncorrected myopia, you all know patient has poor accommodative effort because patient has naturally focused veneer, but because there is poor accommodative effort, then the exodeviation can manifest. What about hypermetropia? So if exotropia is coexisting with hypermetropia, what happens? So first we look at high hypermetropia. What happens when you have high hypermetropia? How much can you accommodate? Suppose you're +7, +8. You cannot accommodate all that too. So you will just give up. So you cannot accommodate to clear the blur. And so the you will just let go and the exodeviation may become manifest. What happens when in moderate hypermetropia? So moderate hypermetropia, yes, you give glasses. Now, the patient might have been masking the exodeviation with accommodation, right? Uncorrected hypermetrop, they try and accommodate to clear the vision. Now, you gave glasses, accommodative effort is gone, and the exodeviation can become manifest. So those are the relationships between refractive errors and exodeviation. Now, let's move on to classification. Now, as you can very well expect in a topic like exodeviation or anything in strabismus, there are so many theories, there are so many stalwarts, all arguing, all having their own points of view. So you have classifications by Duane, then Belchovsky and Burian and Jampolsky and Kushner and so on. But what do we commonly use is Burian's classification. And that goes like this, and we're going to look at it in greater depth later on. So you have divergence axis, simulated divergence axis with tenacious proximal fusion. Hang in there with me. Don't run away. Don't get scared. Okay, simulated divergence axis based on +3 lenses at near. Basic convergence insufficiency. I've just shared this for you to just look at it. Don't get stressed about it. We will understand what exactly is this classification a little later. So where do you see exodeviations a lot? And someone noticed it was seen more in regions closer to the equator, like say our population. It seems to be higher in Asians, more in women. And like I already explained to you, often starts at birth, but kept in check by fusion and accommodation. So it is very important to note when this started, because intermittent exotropia, which starts later in life, which is noted later in life, has good prognosis as far as stereopsis, fusion. Whereas congenital exotropia does not have very good potential for good grade of fusion and stereopsis. So it is so important to get that history. Okay, how does a patient of exodeviation present? We're not going to talk about the differential diagnosis, the ones that we looked at, that list. We'll just look at these simple ones. patient with exophoria, that is, the eyes are trying to deviate, but not in the manifest state, they may present with diplopia, visual disturbance, eye strain, headaches, because they're constantly trying to keep the eyes together. Intermittent exotropia have this very interesting phenomenon called diplophotophobia, where they seem to close one eye in bright light. So that'll be a common symptom that the parent will complain of. They'll say, you know what, whenever he goes out, he closes one eye. So monocular eye closure. And sometimes they will have decreased vision when both eyes are open. They'll come to you and say, whenever especially little older patients who are recompensating, intermittent exotropia, who've been doing well for years and now slowly decompensating, they will say, every time I try to control my deviation, my vision becomes blurred. Obviously, what they are doing is accommodating. So when you accommodate, you become myopic, and then your distance vision becomes blurred, and then you have micropsia. Constant exotropia patients typically have no symptoms. Okay. Let's take some more history. It's just this is not enough. We need to know why this exodeviation happened. So you want to know history of prematurity, ROP, developmental delay. Why is it important? Because you may have a pseudo-exotropia because of macular dragging, if this was regressed ROP. Developmental delay, it's important because your results may be unpredictable. Results of surgery for exotropia may be unpredictable. And as we already talked about, if it's present from birth, the potential for fusion stereopsis is less. Viral illnesses, vaccinations, these can make a well-controlled deviation manifest, decompensate. So that is also important to find out. Trauma. Trauma may be usually to the eye or to the head. Eye trauma with any decreased vision, high femur, could have been the starting point of the exodeviation. Some exodeviations occur in family. So you may want to get a good family history. And we already talked about the monocular eye closure. Okay, now you've asked a good history, and here is a patient in front of you. Now we are going to move on to clinical examination, right? Now, while I have put this chart here, visual acuity, both monocular and binocular. Binocular means both eyes open. I just talked about that, right? If both eyes are open and the patient is trying to crank in that accommodation to keep the eyes together, the distance vision, that is both eyes open vision, will actually be less than individual eye vision. Now, while I've put this visual acuity here and a few points here, I really want to tell you that you must measure the fusion and stereopsis before you measure vision. Because to measure vision, you will cover the eye. And so if in this patient, the fusion is very tenuous, it's very tentative, it might break. Just the act of covering one eye may break the fusion. And then you will think that this is a constant exodeviation, whereas the patient may actually have fair control of the intermittent exotropia. Okay, so keep that in mind. I'm going to quickly cover these 2 points. So the deviation measurement, we want the accommodation to be minimal. So you use the 6'9" target at 6 meters. Far distance measurement is even better, because there are theories which say the farther you take the target away, you will really uncover the maximal deviation. And you need to know the maximal deviation if you want your surgical interventions to be successful. Okay, so again, vision, you want to keep accommodation minimal. So choose a 6'9" target, always measure at 6 meters or even further away. So really understanding how to approach intermittent exotropia clinically, it banks on these 2 things. What is the sensory status and how is the motor control? What do we mean by that? If your sensory status is good, it means the patient for most of the time is able to keep the eyes working together, which means you don't have to do anything. okay? Or you have to do very little. And the motor control is the actual act of keeping it together. And the sensory status is the sensory advantage you get because the motor control is good. So let's look at a little bit more in detail about this. So how do you measure the sensory status? There are near stereopsis, many types. There is Titmus, there is Randott, there is TNO, there are Lang. There are many, Frisbee-Davis. There are many ways to measure the near stereopsis. But remember, we talked about it. At near, the patient will crank in what? Accommodation, fusion. Okay, that is motor fusion and accommodation. And so the near stereopsis will usually be very good, even very late in the in the condition. As the disease progresses, the near stereopsis continues to be very good. So it will give you a false sense of security. All is well. Yes, my patient is doing well. No, distance, the patient may just be decompensating. So what do? You can measure distance stereo test, not available everywhere, but available in institutes for sure. And we'll hear from Dr. Pradeep Sharma. I know he had an article he wrote about distance stereopsis in their institute. So distance stereo test will really give you a better picture of how well the patient is doing sensory status at distance. All right. Okay, so let's look at this patient. And this I've put there to tell you that sometimes if you are not, this is the patient is an adult, was able to give vision 6/18, but sometimes you'll have to look very carefully in a kid to see if there is strong preference in the presence of exotropia. And you can see in this particular video, the right eye is central, steady and maintained, and the left eye is central, steady and unmaintained. So we're going to see this video. There, she's fixing gives a target. Left exo takes a fixation. Aha, went back. Right is fixing nicely. One more time. Left exo takes a fixation. It goes back. So you already know that the vision is 6/18. You've recorded it, but this is an additional information. The patient has a very strong preference for the right eye, and the left eye seems to have an exotropia. And I don't know if you can see it, but a small hypotropia as well. It's out and a little bit down. So let's talk a little bit more about motor control. So it's nice to have a scoring system so that you're not writing long passages. Patient broke with a single cover and then did not recover for the next 5 seconds. Imagine doing all this. So it is easier if you just have a scoring system. And there are 2 scoring systems for simplicity that I'm going to introduce here. One is called the modified Newcastle score. The other is called PEDIG scale. Now, some of you are wondering, what is this PEDIG? PEDIG is Paediatric Eye Disease Investigator Group. This is a group that was formed with the funding of the National Eye Institute. And they put together many multi-center trials. They conducted many multi-center trials. They started with amblyopia treatment, but they went on to study other things as well. So in one of their studies on intermittent exotropia, they used this particular scale. And so we're going to look at that scale. What does the scale really mean? What does this motor control and scale, what does it really mean? What it means is you want to have an objective, easy to record way of knowing how well the patient keeps the eyes together. So you wish to know the control for near, control for distance, and the modified Newcastle has one more element, which we'll talk about. Then you calculate the score and you compare it with the previous visits. That's all it is, okay? So this is the PEDIG office control scale. And if you look at it, 5 is constant exotropia, 4 exotropia that is seen more than 50% of the exam before dissociation, and 3 exotropia less than 50% of the exam before dissociation, and number 2, no exotropia unless dissociated. What do you mean by dissociated? Covering the eye. That's what we mean by dissociated. So in 5, you just seen, that's it. In 4, the patient is able to control the deviation, but still it's seen 50% of the time. And in 3, it's seen less than 50% of this time. You've not covered, you've not done anything. You're just looking at the patient and you can see the exodeviation. And 2, no exotropia unless dissociated. So you cover, you take off, the eye has gone out, but in 5 seconds, more than 5 seconds it takes and it comes back. In 1, it recovers even faster. And in 0, recovers in less than 1 second. So this is really an exophoria. So this is the Paediatric office control scale. Very simple. You use the same scale for near and the same scale for distance. And you note it down. So this is the revised or the modified Newcastle score. Now, if you see this, it looks fairly similar to the other one, except they have added the home control as well. So how are you going to do this? So I usually tell the parent to keep a sort of a diary or keep a little paper pinned onto or the magnet onto the refrigerator. Pick 1 day a week. Yeah, every day you cannot be looking to see whether the child's eye is deviating, whether the child's, you note down. Really, they have other things to do, right? So I tell them usually pick a day in which every time you see the eye deviating, put a line there. Put a date, put a line. So at the end of the day, how did you see it more for distance? Did you see it even when the child was looking at you? Whatever it is, you never saw it. All this can be scored for home control. Now for near and distance, it's very similar. It's 0, 1, 2, 3, which means immediate realignment after dissociation, realignment with the aid of a blink or refixation, remains manifest after dissociation or prolonged fixation, and manifest spontaneously. So as it goes higher in score, it means the control gets worse and worse. So don't worry, I'm not going to be just talking. We're going to look at some example as well and apply the score. Okay. So the next child I'm going to show you, the parent notices the eye deviating more than 50% of the time for distance. So when they see the child during the day, they see it a lot. Okay, remember that history. Now, at near, there was immediate realignment after dissociation. Remember that. And for distance, the deviation remains manifest after dissociation. It was just seen. It wasn't seen right away, but the moment covered the eye, took it off, it was seen. So here we have the kid here. As I told you, near, you just could not see the deviation, but I covered and took off the cover. Aha, you can see that the eye has deviated, right? So what is the score now? Okay, home control. Parents saw it more than 50% of the time for distance, so that is 2. Near, immediate realignment after dissociation, so that's a 0. And distance, it remained manifest after dissociation, so that's a 2. So his score is 2 plus 2, 4. So the advantage of this is it is very, very useful to follow the patient longitudinally to see whether the patient is maintaining control, whether the patient is the control is deteriorating, and then you can decide whether you need to intervene. Okay, so this is another example of how patient. The other thing you can note that the eye with the poor vision sometimes will also fixate very sluggishly. So just let's look at another example of an alternate cover test in a patient with brisk fixation, sluggish fixation. Again, a brisk one and a sluggish one. Okay, this is a very good video. It will show you control for near and control for distance. Look at it very carefully. Here it is. Child is looking at a target, near target. Just watch your eyes. Small deviation building on alternate cover test. Did you see how quickly she brought it back together? Okay. So this is what you need to observe for near. What happens when you cover, uncover? What happens when you alternate cover? And as the deviation, and once you take off all the cover, how quickly the patient is able to bring the eyes back together. The same thing for distance. Watch the next video. There, you can see very clearly she is dissociated, she's deviated with the cover for distance, okay? But again, she will try very hard to control the deviation. Just watch. There, you see with the blink, she brought it back. Ah, she's really trying to use her accommodation. Now it is manifest the whole time. So this would be a 2. There, she brought it back together. So that is exactly what you need to note down. An alternate cover test for near and cover test for distance. What happens to the eye? With cover, uncover, do you break the fusion? And how quickly the child brings the eye back together. This is what you need to note down for near and for distance and calculate the score. Okay, great. What else do we need to do for a patient with exotropia? These are the next things that we have to do, and we're going to look at a little bit more detail about each one of them. You have to find out if this exotropia, especially if it is constantly deviated in one eye, constantly occurring in one eye, and always only one eye is deviated, has that eye become amblyopic? Is there strabismic amblyopia in that eye? You have to find this out because it is so important to find this, treat the amblyopia, and then only plan the next correction or whatever you want to do. The second thing you want to know is their distance near disparity, which means is the deviation different for distance, different for near, okay? And why is that important? We're going to look at it in just a few minutes. The third thing that you need to find out, is there a coexisting pattern? Is there an A or V pattern coexisting? What is the refractive error? And this is important because refractive correction may sometimes all be needed to improve the control. You give a refractive correction, the vision improves and the control improves. You have to look very carefully at the media and fundus because you want to know whether there is a sensory exotropia. Is this a sensory exotropia? Okay, then the whole game changes. Okay, so let us look at an example here. This is a 23-year-old gentleman. Vision right eye 636, left eye 66, completely normal eye exam, no refractive error. So what is the diagnosis? Strabismic amblyopia. You have to treat this before you do anything else. And there is treatment available even for adult amblyopia. So, but that's a different topic altogether. Distance near disparity. So look at this girl here on the left side. You can see she's looking at a near target and there is hardly any deviation. And just like the example you saw of the child in the video, and the moment you give her distance target, you can see the exodeviation becomes manifest. And so the distance angle is much larger. You have to pick up distance near disparity because that is how you will classify the exotropia in order to treat. Now, you have to pick up pattern strabismus is the third thing on that list I told you. So look at this little kid here. You can get a sense that there is some exo happening, perhaps in the right eye. You get that feeling. Now, the child is looking at is looking at you, at your near target. Now, when you give a distance target, look at what the child has done. The child is taking a big chin up to view. Guess why? Because the child is very well aligned here and something is happening at distance there. And let's see what happens if you correct the head posture and make her look at a distance target. This is what happens. The exodeviation has become completely manifest, especially in the right eye. I'm going to go back one more time and show you there. See how well she's controlling or trying to control the exodeviation till you correct the head posture and then you can see it clearly. So this clearly she has a B pattern. Very important to take this into consideration again for planning treatment. So one more time, differential diagnosis. We already looked at the list. So let me just give you an example of differential diagnosis. What all you need to look for is check for incompetence, abnormal head posture, narrowing of palpebral fissure, check for sensory causes, cataract, glaucoma, macular scar. And you can see, the slide is from iFocus 2020. So you can see here that this patient has a left exodeviation. But what catches your attention here? Can you see that the left eye actually looks a little smaller than the right eye? Now, with the bottom photograph, you can see that abduction, abduction in the left eye is limited. And in the upper photograph, you can see that adduction is also limited. And there appears to be some globe retraction and narrowing of the palpebral fissure. So this is exoduanes. This is exotropic Duane's retraction syndrome. This is not your simple exotropia, constant exotropia. Important to make this distinction because the treatment is completely different. So now, as I had promised earlier, we are going to come back to the classification and try to understand how to classify with some actual numbers. Okay. Okay. Patient number 1, near deviation is 30. Distance deviation is also 30. It's the same. So what is the terminology for this? This is called basic type. Now we have patient number 2. Near deviation is 20, but distance deviation is 40. So before you say, what is going on? Is this divergence axis? When I look at distance, the eyes are diverging. Divergence axis. Is this divergence axis? Before you take that call, what we do is we do a patch test. 45-minute occlusion, at least 45 minutes, sometimes even longer. Why do we do this? Because we want to break fusion. Now, what happened once you did the 45-minute occlusion? Look at that. The near angle built up. It became 35, almost close to 40. Distance remains 40. So now what are we going to call this? What are we going to label this? We call this simulated divergence axis with tenacious proximal fusion. So it is basically basic. That is, distance and near are the same. The deviation is the same, but fusion is used to keep the near deviation in check. So some people call it pseudo divergence axis, or you call it simulated divergence axis. Again, it looks like divergence axis until you do a patch test. We have a next patient. Patient number 3. Near deviation is 20. Distance deviation is 40. More for distance. Just like the example we saw. So we did a patch test. Okay. It's the same. There is no change in the deviation. It's still 20 for near and 40 for distance. What do we do? Now you have to rule out that accommodation is not at play here. So you want to test for presence of high AC by A ratio. And a very quick and easy test to do in the OPD is to hold up +3 lenses and see what happens. When you do that, this patient, the near built up to almost distance. So here the diagnosis is simulated divergence axis. It looks like divergence axis when you start off, but it is because of the high AC by A ratio. All right. So be with me. Just 2 more. Patient number 4. The near angle is 10. Distance angle is 35. Now you've learnt by now, if there is distance near disparity, near angle is small, distance angle is more, you have to do a patch test. So you did the patch test, no change. Then you said, I'm going to rule out high AC by A ratio. You held up the +3 lenses, same measurement, no change. Now you call it true divergence axis. Okay. And the last patient, near angle is much, much larger than the distance angle. You can do a patch test for this as well. And this is called the convergence insufficiency type of exotropia. Don't call it convergence insufficiency. That's a different entity. So this is convergence insufficiency type of exotropia. Okay, so I have, this is a bit of an old video, but it's a beautiful video. It'll show you all that we talked about, the patch test, the +3, and so on. So let's take a look at what happens in the skin. So at near, seems to be have good control at near. I really don't see very, very small deviation for near. And then, you can see the single cover. The eye went out. She's cranking in. Now we're actually measuring with base in prisms. What is her deviation? Remember, near we hardly had anything. And distance, it was a lot more. Single cover, breaking, it's coming back. Such a super cooperative kid. Look at that. Single cover. It came back. Single covers is staying out. So now, because I know near is hardly anything in distance, I'm getting a deviation. I've done a patch test. So I'm telling her, don't open your eyes till I place the cover. I put on the glasses and place the cover. And then, this is always a tricky thing. Make sure you don't stick it on the hair of the kid, and then you lose the cooperation. So here the patch is coming off. Glasses are on. And I'm going to see whether we have built up the angle for near after the patch test. Not really. Not much is happening. So now we're going to try and... So we've ruled out this is not because of fusion. We're going to see whether high AC by ratio will... I don't know if you can tell. Deviation increased. There, you can see the eye moving much, much more even behind the lenses. And so this is possibly simulated divergence. There, you can get a closer view. One says 2.5 because you couldn't find my 3. You can see clearly the deviation is built up to a lot more at near. So this is simulated divergence X's with high AC by A ratio. Okay. So how are these, how is this classification important? How is it going to help you manage your patient? All this we're going to see in part 2. So in conclusion, assessment of stereopsis and motor control are the key. Please use a scoring system. Keep differential diagnosis in mind. And the type of exotropia based on the classification will guide the treatment. And it's important to identify amblyopia and refractive errors and treat them. And thank you once again, Santosh and Dr. Pradeep and the CFS team. Thank you so much.
Thank you so much, ma'am. It's always a pleasure to listen to you. Such a clear, crisp talk as always. Pradeep sir, your inputs.
Wonderful, really, and so much interactive. I mean, it's really a pleasure to see that. And I think she has shown very illustratively by giving examples of the different types of exotropias that one may encounter with the nice videos. So I think we should go on with the questions if there are any first.
Yes, sir. So the first question from our audience is, can you please explain fusional convergence?
You're muted.
Yeah. So fusional convergence is because of, it's a function of the medial rectus. It is also comes because you want to keep the object of interest on the fovea. So you used mechanism, use the fusional mechanism, fusional convergence mechanism to keep the object of interest on the fovea, as opposed to accommodation, which is the other way in which you will stimulate the convergence mechanism. Would you like to add to that, Dr. Pradeep?
Yeah, I think you have rightly said that basically we know that there are 4 or 5 types of convergences that we have. The more common ones are the fusional convergence, the accommodative convergence. Then there is one which is tonic convergence. That is when we see that under the anesthesia or when the person is at totally position at rest when he's dead, then the eyes tend to diverge out. So that is the tonic convergence. And then we have a voluntary convergence and of course a proximal convergence. So there are 5 types of convergences, and you see the interplay of these in some of the examples which ma'am had shown, that you have simulated divergence access because of fusional convergence working, and that we see as exotropias which are breaking, exophoria versus an exotropia. Then we have the simulated divergence access because of the proximal convergence or a tenacious proximal fusional convergence, which is causing a exodeviation to be smaller amount for near because of the TPF covering up, or nowadays called the Scobie's phenomenon, or excessive exuberance of the binasal disparity, as described by Kushner. Then you have the accommodative convergence, which is the person is trying to have extra accommodation, which is actually only meant for near, but he's using maybe for distance also, and then he may have an accommodative convergence. And of course, then the voluntary convergence, some people may have that they may try to have a convergence. So these are different types of convergences. The fusional convergence, as was asked, was a special type in which you are able to have the exodeviation overcome by your fusional efforts. So this is a fusional convergence which works both for distance and for near.
So the next one is, how do we differentiate pseudo-convergence insufficiency versus fusional convergence insufficiency in intermittent exotropia? Okay.
I honestly don't even understand the question. Can you repeat it?
The question is, how do we differentiate pseudo-convergence insufficiency versus the fusional convergence insufficiency in intermittent exotropia?
I think what he's trying to ask is like what you said in the last, no, that there is a convergence insufficiency type of exotropia, right, as against a fusional convergence insufficiency.
Okay. So
a normal person could be having a fusional convergence insufficiency.
Right.
That is one thing. So,
right. So convergence insufficiency, the term convergence insufficiency, when we use it isolated, it usually means there is no deviation for distance. All what is happening is only at near. So here they usually, what they have is either the convergence amplitudes are reduced, and or the NPC, or the near point of convergence, is receded. And so these patients will sometimes use an accommodative effort to overcome that convergence insufficiency. But these patients typically do not have exotropia at distance. Okay, so remember that this is a separate entity in itself, as opposed to convergence insufficiency type of intermittent XT, in which there is deviation for distance, there is deviation for near. It's just the near angle is much larger than the distance deviation. So that is a separate entity.
The important thing is that when we are talking of fusional convergence insufficiency, which is very common, I think we see that almost 1/3 of the OPD patients, if you see, they may be having some amount of fusional convergence insufficiency. They may not have necessarily a manifest exotropia. So most of the people who are doing near work and have eye strain may be having a convergence insufficiency, which is, when we say loosely convergence insufficiency, we are actually meaning fusional convergence insufficiency is there, as against a convergence insufficiency type of exotropia, which may not have a fusional convergence insufficiency, but they have a difference in the exotropia measured for distance fixation and for near fixation. For the near fixation, the deviation is larger, and for distance, it is lesser. Then we say it's a pseudo convergence insufficiency or a convergence insufficiency type of exotropia.
So the thing to remember in convergence insufficiency, the patient often will present with asthenopic symptoms. These will typically be somebody who will be working on the system or doing near work for prolonged periods, and they will be, the whole convergence insufficiency will be masked sometimes because they will be using an accommodative convergence to overcome their reduced convergence, near point of convergence. So the tip there, the clue there is that they usually will present with eye strain and will not have a deviation for distance.
And these are improved by giving the exercises, like convergence exercises, which we give, they will be very nicely be benefited by that. So because they have no other deviation as such, it's only a near convergence insufficiency, which will be improved by the properly done pencil push-ups or the convergence trainer on the card, or maybe the Brock string exercises, which are done for improving the convergence exercise.
So the next one is, what are the factors which may cause progression of intermittent exodeviation to a constant exodeviation?
So there is, most importantly, the natural history of the disease itself. The natural history of the disease in certain populations is such that it may, the exodeviation may progress. Sometimes it is the start of, say, presbyopia, or the early onset of presbyopia. Sometimes an exodeviation that has been kept in check can become manifest. Sometimes it is, you can even see in slightly older patients, it may be the onset of cataract. Anything that's interfering with fusion in terms of decreased vision can also cause a progression of a well-controlled exodeviation. Would you like to add, Dr. Pradeep?
I think what she said is right. I can just put it in different words again. That one could be that because of aging, your ability to fuse becomes less. The other could be there is a suppression which is developing because of intermittent exotropia, and he's developing a suppression, or then it can be further worsened. As we see in the Calhoun's classification, that from exophoria it moves to intermittent exotropia, first for distance and then for near, and then finally a constant exotropia. So these are in a way phases or stages of the same phenomenon which is happening. You're losing the binocular fusional ability because of one, aging, increase in the deviation by itself, or it may be because of increasing suppression which is happening. So any cause of poorer vision would cause this. If you are having uncorrected refractive errors, it may be likely that you will go in for a manifest deviation. If you are corrected in time, you will probably be maintaining yourself properly. So these are all factors. It may be refractive error, the aging, the suppression which is developing over a period of time, which causes exodeviation to become from latent to manifest.
Next one is, can you please explain about the suppression scotoma developing in cases of exotropia?
So the typically the suppression, and we'll cover a little bit of it in the part 2 because it's in relation to planning surgery as well. So in intermittent exotropia patients, when they are aligned, that is when they are in the fused state, they usually are bifoveal fuses. That is their state of fusion. When the deviation becomes manifest, then they have hemiretinal suppression. But with time, this hemiretinal suppression with constant and increased deviation of one eye, perhaps with aging, the patient can slowly develop a central suppression as well. So usually those are the stages you go through, where you are bifoveal fuser, then you can also have a hemiretinal suppression, and then you may develop central suppression as well.
Anything that you want to add, sir?
No, it's right. Basically, any misalignment causes a twin point scotoma. But because we had talked about in the binocular vision earlier foundations lectures, that whenever there is a misalignment, there would be two things. One is the suppression of the fovea, which is receiving two different images, and that is also known as the Harm's scotoma. And the other is the diplopia point, the other point which is now getting diplopia. And because he would not be liking that, he would try to suppress. So classically, whether it is an esotropia or exotropia, they will have twin point scotomas. But in exotropias, generally we see a single large scotoma, which is merging the central as well as the diplopia point. And Jampolsky had described this as hemifield scotoma. But with the lesser dissociative tests, we also have seen, and I think Kushner also has described, these are single large scotoma rather than a full hemifield scotomas. So basically it's the same thing. It's the diplopia point and the central point scotomas, which in exotropias are larger because of probably the intermittence, the variability of the exodeviation, that they keep on having a changing goalpost. So they will have a scotoma which is going to be larger and finally merging the central scotoma as well as the diplopia point scotoma. The importance of this is in the surgery. I mean, when we are operating, then we find that if they have this scotoma, they are not going to be complaining of diplopia easily if they are undercorrected. But the moment you overcorrect them even slightly, they will complain of diplopia, because then it comes out of the suppression scotoma, whatever point you have now given. So if you overcorrect an exotrope, he would then complain of diplopia. But in adults, we say that, okay, we want a little bit of overcorrection done. So they have a little diplopia, but then this helps in the binocular stimulation. Whereas if you leave them undercorrected, they will have the benefit of not having diplopia, but probably the exodeviation tendency will still happen. And over a period of time, there will be a worsening of the exotropia and probably what we say as the recurrence of exotropia partly.
And the last question for the evening, sir, is how different should the clinical approach be in case of concomitant exotropia versus DRS?
The clinical examination steps are essentially the same. The only real difference will be in ExoDRS, for instance, you would want to know if there is an abnormal head posture. You want to know other phenomenon that like, globe retraction or any upshoot and downshoots. All these things you would make note of. But the approach is essentially the same. Also, measurement-wise, you will want to measure primary and secondary deviation, is likely to be different. But what is essential is not to presume that every exotropia is just a constant exotropia, but to remember that the exotropia could be because of many other causes, one of which is the DRS. So in summary, you have to look at if you find a prominent head posture, a face turn, and if you find there is limitation of ductions, if you find there are coexisting other phenomenon, then it's going to be more likely in favor of an ExoDRS.
It's important to differentiate because in ExoDRS, you won't be doing a resection of the medial rectus, whereas in an intermittent divergent squint or exotropias concomitant, you may do either a R&R or you may do a bilateral recessions. That is a choice, but you may have a resection as a or possibility, which is totally contraindicated for venous retraction syndromes.
So with this, we wrap up the questions for tonight. Thank you so much, Meenakshi ma'am, for giving us your valuable time this week, and Pradeep Sharma sir for giving us your valuable time every week and being the cherry on the cake, as sir mentioned. Thank you. Sir, any last concluding words from you?
It's wonderful. I think, thank you, Shefali, for chairing it, moderating it so nicely. And I think Dr. Meenakshi, as I always say, it's a pleasure to listen to her because she gets involved and she keeps us involved. So that's wonderful. So we will be eager to listen to the second part of her talk on exotropias.
Yes,
I think.
Which that will be on 26th August. That is the masterclass part 2, which is exodeviation terminologies, classification, etiology, symptoms, signs, diagnosis, and treatment with case examples. So see you all on Friday.
Look forward.
Thank you. Thank you.
Bye. Bye. Good night.
Good night.